Afternoon, everybody. Thanks very much for joining us today. I'm Claire Sherry. I'm part of the change team within the Improvement Service, and alongside me today we've got Kelly Hunkin and Gerard McCormack, and what we're doing is we're kind of taking over from Dave Morton, who you'd be used to speaking to or hearing anyway on the webinars. So bear with us, it's the first one. Hopefully we've got all our handover instructions and everything goes smoothly today. But just to kind of run through some basic housekeeping before we hand over to the presenters. Obviously this session is part of a session of 3 and it's part of the Change Managers Network. What we'll do today is basically the presenters. We've got Thomas Dodd, Thomas Monaghan and Diana Hekerem, and they're going to kind of run through about informing decisions and about using data. After they've done their presentation, we'll be kind of opening it up for questions. So if you have anything, even just as you go through it, just fire it in. On the right-hand side, you should see a little box saying questions. Just send them through, and what we'll do is we'll pick them up at the end of the presentation. Likewise, any comments, etc., that would be all helpful as well for us. The presentation and any of the discussion points will be recorded, and any materials from the session, including the recording, will be all on the Knowledge Hub after today. And after we've done the presentation, we'll also be doing there'll be a short survey that you'll get a link to. So if you've got any feedback for us or any ideas about how we could do any of the webinars going forward, please fill that out. It'd be really helpful for us. And I guess that's everything from me. So I'm just going to hand you over to the team for our webinar today. Thank you.
Thank you. Hi, I'm Dana Hekerem. I'm the Head of Strategic Commissioning Support in the Improvement Hub at Healthcare Improvement Scotland. Thomas Monaghan is our lead for Living Well in Communities, as well as acting lead around strategic planning, and Tom Dodd is an improvement associate who works as part of our tailored and responsive improvement support team. This will take you through some sort of tips around doing population needs assessment. Tom, if you move on to the next slide. So we'll take you through how we can use data for improvement, so that if the data is at the core of everything that we do, but around that is the improvement support that takes you through the understand, design, implement and evaluate. Today we're really going to focus on that understand part of that picture and have some discussions, as I say, some real life examples and some practical advice about how to best integrate the data that's now much more available from ISD and from the local list teams that are in each of the health and social care partnerships, that combines all these data sources together into this integrated portal, and how that can help us through our strategic planning. Tom, over to you.
Thanks very much. So to pick up from our first session, we've based this series of webinars around the fairly well publicised commissioning cycle, which you can see on the screen just now. For the purposes of today, as Diana's alluded to, we're going to focus on the assessment of need, both around individual and population demands, and think about how we can use a better understanding of need and the data that informs our understanding of that need to set our priorities for service commissioning and to address any gaps that we might perceive. One of the really important parts of this that actually isn't necessarily very well illustrated in the commissioning cycle is the need to consult and engage on a co-produced basis with the people that might be affected by our use of data. So one of the main points that I want to get across as we're talking today is, while I'm sure you're all very well versed in analysing and understanding data, but the need to present that data to people in simple and effective ways. So I want to talk a little bit about needs assessment, and I guess the starting point for that is thinking about what need actually is. These definitions have been around for some time. The guys in Birmingham, that's a paper dating from the very early 70s, and they presented an understanding of need as the population's capacity to benefit from health care. In the context of partnership working, of course, we'd extend that to care more generally, but that notion of capacity to benefit, I think, is as useful definition of need as any. Bradshaw in 72, working also at Birmingham, went on to describe 3 different types of needs. So those were needs as perceived by the individual, And I think there's an important point here that there may well be a sizable proportion of the population who perceive needs but don't go on to express those needs or seek help or services from us. Understanding the differences between the two is very challenging because those people who perceive need but don't express it are usually invisible to our services. The third definition, which I'll touch on but not go into very much detail about, is the notion of normative need. And we need to be quite careful about this, actually, because that's need as it's defined by experts in Bradshaw's view. I think that means us. These are needs that we might understand from the population analysis, but these are not always the same as the needs that people would feel on a day-to-day basis. And an important point throughout all of this is that those needs are not the same as demands that they might make of services. So to think about that overlap between need and demand, and in fact the aim of strategic commissioning here is to get us from relatively disparate understandings of need, demand and supply, and to make those three circles overlap so far as we can possibly do so. So in reflecting those definitions, need here is the things that people might stand to benefit from. Demand is the things that people ask for, and supply are the things that are provided. Now, those can be very different. The usual sort of examples here are things like a demand for prescription for antibiotics for a cold that are neither supplied nor really needed. There are three main ways to think about assessing population need. These start with arguably the simplest, which is a comparison of services received by one population with other populations and with appropriate standards. Now that begins to assume that those populations are broadly similar in the needs that exist within them. We'll explore that in just a moment. So moving then into more complex approaches, and we'll spend more of today looking at these. There's an epidemiological approach to assessing population need, which can either be done on a whole population basis or for very specific conditions. And that takes a data-led approach to examine the incidence and prevalence of particular conditions or the need for services, and balances that against the effectiveness and existing cost effectiveness of services that are currently being provided, a gap analysis, if you will. The third element has been described in academic literature as a corporate approach to population need, but I think certainly in Scotland we would regard this now as a co-produced approach to understanding population need, which is about seeking views, demands and the wishes and actually different perspectives of various people associated with the presentation and delivery of services. My view is that the epidemiological and the corporate approaches to assessing population need to exist alongside each other, that you can have the best set of data in the world, but unless you've taken the co-production approach, the delivery of services with it will always have something lacking. To touch for a moment on the comparative approach, this is an approach that in its underpinnings assumes that your wider population broadly expresses the same sort of needs in the same sort of ways, depending on which area of the country or the region that you're in. So it contrasts the services that are received by part of the population in one area compared to part of the population elsewhere. And that actually, if you're limited in the data that you have available to you, is a perfectly reasonable methodology. We can take some broad assumptions about people's needs and think about the way that services are provided to them. You don't need to know necessarily the absolute level of need, and in fact the methodology precludes it, because what you're doing is you're comparing the levels of services. So you're assuming in this process that the needs which are present but not expressed are done so to a similar sort of extent, regardless of the area of population that you're looking at. So we see examples of this all the time. This is Scottish data for A&E attendance rate, and it's a comparative approach. In some cases, you might make the argument that the comparison between areas is relevant. You could, for example, consider perhaps the population of Fife and South Lanarkshire as broadly similar, and maybe those contrasts are appropriate. You might think, I think elsewhere, we generally might regard the populations of Angus and Murray to have broadly similar characteristics, although anyone that's here from Angus and Murray will probably be jumping up and down in their seats at the moment. You wouldn't necessarily make the same contrast between somewhere like the Western Isles and West Lothian, because we know that the geography and the population of those places is very different. So we would tend to wish to build further on the data that we have available to us to deliver a better understanding of the needs of the population, particularly locally, in light of locality-based planning. And to do that, some may be aware that there's a variety of existing resources. So these have been developed, some recently, some are very well established. Think about different profiles, indicators, population health survey data, and general evidence on health inequalities, which would start to help us build an analysis of the needs of the population in our area of interest. In Scotland in particular, we have a wealth of local and national data sources, and in particular the links here are made with the LIST team, and there's a variety of sources that can be added to both NHS and local authority information to help us develop a broader understanding of the types of need that might be extant in the population of our interest. These sorts of things cover indices of multiple deprivation, the degree of housing and homelessness, the degree of social services provision, and more recently a far greater understanding of the needs of those individuals who use considerable volumes of resource, and understanding also a bit better the integrated flow between services. This has relied very heavily on linkage of health and social care data so that we can understand the needs and requirements of particular individuals as they flow through the various elements of the system. Thomas, if you're there, I'll pass over to you for the next few slides so you can talk about that in more detail.
Thank you, Tom. So my name is Thomas Monaghan, and as I lead the 11 Million Communities team at Healthcare Improvement Scotland, and the aim of 11 Million Communities is to enable more people to spend time at home or the homeless setting that would otherwise have been spent in hospital. I'm also providing support for strategic planning. And I'd like to give some examples of how we're using that linkage of health and social care data with partnerships. And thank you, Tom. So this slide you're seeing now is an example of SOURCE. For those of you who are not aware, SOURCE is a data set that ISD manage. It's a national data set. And it is, like all national data sets, it's from data which is submitted locally. But the benefit of SOURCE is it links all the various data sets together by the KI number. So for each individual citizen, you have all their data of service use and resource use linked together. Now at the moment, the data is quite heavily health focused and acute focused, simply because that has traditionally been the data that's been available nationally. I think at the moment it covers about 80% of health spend. That is changing across Scotland as the Health and Social Care Partnerships sign their information sharing agreement with ISD. Social care data is then seeded with the KI or matched with the KI and is also added to this database. So it's possible for an individual citizen to see how much health and social care resource and services they use. And they're also developing this further. There's an intermediate care data set being created, which will likely to be joined, a palliative care data set. There's, I believe, housing and homelessness will also be added in. And with the development of Spire to access GP data, it also opens up the options for GP information to be added in the future. And I believe the allied health professional community team data set, which is being created, that can also be linked in here. So in terms of our system and resource use, this linked data set, it's currently a fantastic resource, but in the future as it's developed further, it should cover most of the statutory health and social care services. And I like to point out when I talk about social care, that includes the commission services. And what we've been using this for, with the help of ISD and particularly the local LIST teams, is to turn, Tom, can I ask you to move slides? Is what ISD have developed is, instead of just having traditional data and data sets, the ability to visualize this information in a relational manner to show where people, what services people use and in which direction. And so this is an example of that. So what we've done here is we've looked at the resource use across health and social care and narrowed down into the largest resource use segmented that down into individual care groups, and identified that palliative care, or the end-of-life care, is one of the largest areas of resource use. So to explore that further, ISD were able to take a sample of the data for that population group, the end-of-life population group, and identify what services they're using, how much they're using, when they're using it. And this is the example. Now this is an example at a GP level. This can be broken down to different geographies. So this is a GP. It could be to a GP cluster, a locality, a partnership. It could be individual data zones. It's just, but there is a warning. The more data you use, the bigger the area, the more complex this map becomes because of the amount of variation in possible routes. So to help that being simple, to help simplify that, we've developed maps. And Tom, can I ask you to move that on? So this is an example of the palliative care map for Glasgow. It's a very high level of all these services across health, social care, the third sector, independent sector, that are supporting people to live well at home. And what we use this map for is we take this map, plus we take the data we've generated from the previous slide, and we start to map on who's using what services, when they're using it, and such like. And then we take individual patient stories, take information about individuals, and we walk them through this map. And largely what we do this for is we're understanding why people end up using services where we didn't expect. So in this case, for the coordination of palliative care, it's often why do people end up in acute hospitals, and it's sometimes quite sad because when you look at the data, it often appears as though people sometimes ping pong between acute home, which in terms of quality of care, I know if that was one of my relatives, if that was my gran, I wouldn't want that for her. The fear, the anxiety that must cause for people must be devastating, and the cost resource to the service is relatively high. So we take the patient's story to understand why they're going to acute, and when we're doing that, one of the things we have learned is that there's often alternatives in the community and they're not used. And by mapping the patient's journey, we can see then what part of that patient's journey we expect there to be a different response. And that allows us to ask the questions of why did they go to the hospital at this point? Why didn't they go to this service? And that allows us to really narrow down where we think there's a need for change. And sometimes that's an improvement exercise. It's an improvement program. Could be education about a new tool or something. Or sometimes what it really reveals is that there's a need to change the system, to increase capacity or change capacity within the system. Tom, can I ask you to move to the next slide, please? And the slide has lost its formatting, unfortunately, but it's the same picture. So what we have done is, once we start to understand what causes people to move into particular areas, into particular services, it allows us to start to put that into more of a flow. And then we get to ask key questions along that flow. And then we also, and what we're developing now, are models and tools so we can start looking at capacity within each of these boxes in different parts of the system. So that when we walk someone's journey through the flow, we can then decide, well, actually, if we want to make a change, say, in supporting the community, how much capacity is there to do that? And how much new capacity do we need? And where could we possibly shift demand? If there is demand going into acute, for example, what is it we need in the different areas of the system to develop that, to give an alternative in the community. And by using this, and say we're still developing the kind of tools to help model that through, and the kind of assumptions we need to make to do that. But the principle behind that is that instead of making, when we make decisions about strategic planning, we're much more aware of the risks, and it's much more informed, and we're using data as data we currently have available to help inform that. I'm going to pass you back over to Tom, who will give a bit of a case study for partnership.
Thank you very much. That's very helpful. So this case study relates to an assessment of need, some work that I was involved in last year. This relates to one partnership. Those of you with a keen eye will be able to spot it, but I'll not talk too much in detail about who it is. This partnership had 6 localities, 209 general practitioners, a bit more than 1,000 hospital beds, 3,500 home care recipients, and 340,000 people. Now that's all lovely data, and it The unfortunate bit about those sets of data is that none of those numbers are either particularly helpful to us in the context of this work, nor are they actually a particularly useful scale for us to get our head around. So the point about this exercise was to try and match some of the sort of thinking that Thomas described around better pathways for individuals with a view of the world from the other end of the telescope, which is about then better care and distribution of resources for the population as a whole. Rather than try and attempt this on the basis of the whole locality, the whole partnership area or each of the 6 localities, we agreed to boil this down to use really a statistical element called a data zone. Now, data zones are slightly smaller than postcode areas. And they are each of a similar size to the other data zones. It's between about 500 and 1,000 people in each one. And these have been designed as a geography to have a compact shape, to have a broadly homogeneous social composition within each data zone, and that's pretty useful when we're doing comparative analysis. And they're also designed to match natural communities, so they wouldn't typically span a river or a road or something of that nature, railway line, that sort of thing. So they tend to respect these boundaries of local significance. This was particularly an issue actually in the partnership that I was working with, and respect then those kind of prominent features of the physical environment. The partnership I worked with had 418 of these data zones, which is a large volume of information to deal with, but individually those data zones contained about 750 people, which is big enough for statistical purposes, but small enough to still be relevant to individual people and their perception of the services that they received. For each of these, we worked very closely with the support that was available from LIST and analysts within the partnership teams who were already present, as well as some external support, to understand and consider then the sorts of indicators which might offer the best proxy for need. And these are the sorts of things that you might expect. So population age, we took the view that older people generally require more services than those in the middle of their life, likewise younger people. The indices of multiple deprivation was used to give us some clues about those areas where either needs might be more significant, or through the rurality components of that index might be harder to provide for because people are just simply further away from the services than their counterparts. We balance that with then a combination of social care and healthcare provision, made possible at this level largely by the Chi seeding that Thomas talked about, and began to use that to start to consider whether, compared to each other, these data zones had more or less, or they had many, or they had few of the sorts of indicators that we were looking at. And we deliberately in that early pass kept away from detailed statistical analysis, although quite quickly got to the stage where we felt that we had to get all this data together in a table and have a look at it. And that, in short, gave us all a bit of a headache, so let's move on from that just now and talk about, very quickly, presentation of that information in a way that was not necessarily for the audience on this call, but to help those people who were not statisticians and were not used to dealing with numbers to get that data in a way that was accessible to them as possible. So a couple of things to think about here. Here's a very simple and obvious set of data, 222, 45, 67, and 100. And 3 different ways of measuring where the middle of that data might be. Now this is pretty abstract, but it ties in with some of the things that I want to talk about later on. So we can talk about the mode of the data, that's the value which occurs most often, fairly obviously 2. The mean, that thing which people mostly would refer to as the average. In this case, in every case, add them all up, divide them by the number, and that gets to 16. Or the median, the middle value in this data set, which is the 4.5 in this case. Now the point of emphasizing the difference between those two is relevant when we come to think about what the data is telling us. Means are very good at emphasizing differences between sets of data. Medians are very good at suppressing those differences and emphasizing similarities between sets of data. So to take one of the indicators, this is from across the partnership, the incidence or the percentage of the population aged 65 plus, and the count of data zones within each of the groups that we've labeled. So we see at one end of the scale there are some data zones who have no over 65s, And that at the other end of the scale, there are some data zones that have an awful lot of over 65. So we would want to set an average number in the middle for comparative purposes. And that's our median. And we use this to then say, well, either are you higher or are you lower than that value in the middle? Now that's a bit of a blunt instrument. So as we've set the median, that's 50% of the way up the data. We can set points at 25% of the way up the data and 75% of the way up the data. In statistical terms, those are called quartiles, and they look about like this. So we now have a combination of very low, low, high, and very high within the data. That leaves out some of the outliers, so we can do the same thing but divide the set of data into 100 parts, and we can have the top and bottom centile. So these are the extreme ends of the range of the data. So anyone below that first centile is within an extremely rare population at the low end of the scale. Anyone in that top centile is an extreme at the other end of the scale. Anyone with children will be familiar with this sort of thing from their weight charts as they were growing up. What does this mean for presenting the information? Well, it very simply gives us some groups with which we can present that data in a way that helps people interpret it. So here's a map of a specific portion of one of the localities we were looking at. And we can see quite quickly, rather than having a graph with lots of bars on it, that we can use those measures of low, extremely low, and low, very low, and extremely low, and high, very high, and extremely high, to get an indication of where density of population or density of need or density of a particular indicator arises. So in this simple example, we can see that to the west of this map we have an area where there is a substantial percentage of the population aged over 65, whereas in that component to the east of the map, where around about where the motorway junction is, the age of the population is in general far, far lower. It contains a far smaller proportion of over 65s. So we used this approach for various of the indicators, not largely as a statistical exercise, but essentially as a way of simplifying the set of data so that people could interact with it. And we found, for example, a couple of fairly interesting features. This, in another area of the partnership, dealt with the proportion of people who were very old in a similar way to the map I've just shown you. And the thing to notice here that puzzled us for a while actually is that there's a very high concentration of over 85s, a top centile in the middle of the map here. Now we, from a data perspective, from the epidemiological perspective, spent a while puzzling about why that might be the case. When we came to discuss the results of our analysis with the practitioners and the social workers in the area, it turned out that actually this is the location of a housing block where housing policy has led to a number of older people being placed in recent years. So to them, it wasn't at all surprising that there was a lot of older people there. It was a direct consequence of a policy that they'd set deliberately. So while it had given us a puzzle, actually reassuring to be able to reflect then the impact of the policy choices that had been made. In another area, it started to help us identify places where, despite relatively similar population characteristics, we see here between Dullata and Carbrain, which is the dark area to the south of the road through the middle here, the population demographic largely is similar between these areas, except for the general affluence of the population is much higher in Dullata than it is in the lower part of the diagram. And we observed then a correlation with care at home provision across the two areas. So it started to help us ask questions about the way that people were presenting themselves for assessment, and also the implications and needs of the people who were being assessed, and begin to design services in better ways. The point, again, of all of this is not to show you lots of maps, but to help think about the ways that we presented information to the people who make decisions, and maybe try and identify some of the issues that we encountered so that you can avoid them in the future. So when we were working through this process, one of the things that we found very early on was that the records of coding and diagnosis, although we've been able to coordinate health and social care information through the techniques that Thomas spoke about previously, we found that if the base data hadn't been coded properly, what we were finding was that those nuances of coding were presenting themselves in the final data sets that we were looking at. We found in particular that the demographic changes between areas was quite stark and gave us a few surprises, so I'd advise a little bit of care around interpreting those sorts of information in light of the supply of care at home in the slide that I showed previously. One of the interesting points in this was that I suppose this notion of supply factors and various limitations to the data were that services that were based around beds, fixed services, tended to be used to their limits rather than at their expected rates based on the population around them. So, for example, a care home tends to be operated at or near capacity. A hospital tends to have beds that are full. Now, that's kind of chicken and egg. You wouldn't have a hospital with beds that were empty. That wouldn't be helpful. But there's a notion here that perhaps because the beds are there, they tend to get used in lieu of other services. So that reflects back then to thinking about those design of pathways. So briefly summing up then that epidemiological approach, what we looked at was the population characteristics and the incidence of disease and prevalence of risk factors within the population, and thought about the way that services were provided in the context of those disease and risk factor prevalences across the localities that we examined. The important part of the process was that we then went on to obtain the views of the professionals, the commissioners, the providers and the users of services. The intention of this was to give ourselves a shared understanding of what the data was telling us. So my example of the housing policy being a useful one to bear in mind here. The sorts of questions we asked, this was operated on a workshop basis. We had maps all printed out and stuck up on the wall, and spent a lot of time with each of the locality teams talking about their initial reactions to the profiles, thinking about whether they felt that the data we had available was reflected in their perceptions of what's going on in their locality, and thinking about elements of the profile that were either useful, surprising, less useful, or quite frankly missing. And there was an iterative process then about generating additional data. Actually, housing and homelessness was one of the good examples that was added in later on in that process. The vital bit here was giving people the opportunity to interact with the data and help us gain a collective understanding. And I think, you know, the benefits of that co-produced approach are well discussed, but this is really in the context of being able to design outcomes-focused services that are specific to local needs, that take into account then the capabilities of the local population and also the quality of experience that they might expect and perceive for their own services. So thinking about the shift between where we started off talking about that kind of expert designed understanding of need and moving that to become a much more co-produced approach to thinking about how needs are evidenced and addressed within the population. So that process then, I think, actually, as I've said a couple of times now, is about identifying those needs, relating those needs to the available resources, and helping the partnership. So not just having then this academic view of, you know, here's a load of data process stuff that we can look at, but using that to try and support the delivery of how local services should be coordinated and organized. Changing context slightly now, just for the final few minutes of the points that I want to make, I want to touch on some of the barriers to data usage that we experienced in that process and that I've seen more generally. And these typically fall into three categories. So there's the kind of individual, and particularly here I'm thinking about individual managers, not necessarily the sort of data analysts or planning advisors capacity to manage data, but helping our managers and our decision makers to be more confident in their use of data, to think about the implications of conflicting evidence, and really to help them bolster their interpretive skills and their confidence in interpreting data in the right way. Some of that is related to the currency and the relevance of the information that we present to them. Some of that is related to the context and the time and the volume and the clarity of the information that we present to them. And there's a set of fairly useful questions actually that we can ask ourselves when we're considering how best to do this. And these set out in a quality and improvement and measurement guide. I've got some links to these sorts of documents later on that will circulate with the slides. Thinking about what the data we're showing are for, or from a manager's perspective, if you're presented with data, ask yourself, you know, why am I being presented with it? Is it up to date? What's it telling me? Do I know how to interpret this form of presentation? Having understand how to look at it, do I understand what it's telling me? Or can somebody else help me do that? And the last and very important point is whether or not I'm being led to a particular conclusion. So I've got a few examples, relatively light-hearted I hope, around the sorts of data that might be presented to managers in the past, and some thoughts on good and perhaps less good methods of presentation. So this is real data. There's a lot of data here. It appears to be telling us something about the average annual hours that were actually worked by each worker. Further than that, I can tell you that the data is old. It stops in 2014 or 2015. I'm not very sure I can discern any particular trends from here. So the presentation of that information, I think, would be best understanding what the particular issue was. This is a point about the time available and the clarity of purpose of the information, and think about how best to present that in a different way. There's very often, particularly in the press, I'm sorry to say I had to go and find this on the Daily Mail's website, an agenda behind the information that's being presented to us. These are a couple of estimates around the growth forecasts for Q4 of 2016. And the way this is presented seems to suggest that the second estimate is greatly larger than the first. But if we present that in a slightly more honest way, we see that the second estimate, all I've done here is change the scale at which it's presented, start the scale at 0. We see that the second estimate is only a very small increase from the first, and there's a wider point about whether in fact they're estimates anyway. We like simple graphics. Very often we see pie charts which present us with information in a simple and accessible way. Pie charts become very difficult to determine any degree of certainty from, except as perhaps shown here. A better way of showing the same information would be to use a Pareto diagram, which is a posh way of describing a bar chart actually. So in this case I've put the data in ranked order, and what we can do very much more easily is relate the proportion of those sides of the pyramid to the overall size of the diagram and to the amount of sky that there is. The nice thing about bar charts, and if you want to use Pareto diagrams, technically you should have a cumulative indicator as well, is that they're simple, they're clear, and they're actually very easy to draw. These really help us with quantities of volume and understanding questions of volume in service need and provision. Excuse me. If we're looking at questions of flow, we might be better using a histogram to help us think about spreads of data. And what follows is a very simple example rather than a detailed discussion. So A&E 4-hour wait. Here's the statistic from a mythical NHS board, which had an 88% achievement of its 4-hour wait target in A&E. Now we can quite simply quantify that information, and we can say, well, look, that was 1,770 people were seen in less than 4 hours, and 242 were seen in longer than 4 hours. As data on a page, that's kind of fine. My own view is that presenting the information like this actually starts to tell us a little bit more about the relative scale between those people that were seen within target and those people that were outside the target. And you can see here that the overwhelming weight of people were seen within the 4 hours. A point here about histograms, and actually very slight point about presentation, I would have joined the bars together, but we can divide those groups into smaller and smaller components, and in doing so helps us get into the degree of detail that we might need to use to change service provision. So breaking down that same set of data further, we can see that some people were seen extremely quickly and some people were seen after the 4-hour limit. And it might be that you would wish to use this information to start to redesign the process, to maybe see people on average a bit less quickly, but in total within the 4-hour target. And that brings us really to the last of the comments that I want to make, which is to then start thinking about the causes of the relationships between, in this case, the target wait time, and think about whether what we're seeing is fluctuation that's part of the kind of natural fluctuation of services, what we would call common cause variation, or whether there's a particular issue, as we can see with the group of outliers on the right of this diagram, that might be a product of some sort of special cause or exceptional variation. And if we're starting to think about improvement and cases for change, we would want to focus on the special cause variation and try to address their needs more quickly. So that's, I think, the last of the comments I want to make today. There's a handful of useful links which will be circulated with the slides for you to help think about a couple of these. Think about the notion of improvement and management. That's the document I mentioned previously. And then 3 sort of statistically focused links that might be of interest for general reading. I think I'll pass back to the guys at the Improvement Service now for Q&A. Thanks.
That's great. Thanks very much for that really interesting presentation there. Just a short reminder for everyone on the call, there's your questions box down on the right hand side, so if you've got anything, if you want to send it through and we can ask it just now. We've got a question here from Craig McIntyre, and he was asking, how difficult have you found ensuring the data is always up to date and refreshed, i.e. when data zones change quartiles?
No, that's a fair point. Actually, what we did was for the exit, it is difficult, and actually a lot of the time we spent was chasing iterations of the data. We had to build a data set, and we had to take the view that we had a picture that was as accurate and up to date as was reasonable, and spend our time thinking about the implications of the data rather than chasing our tail, making changes day in and day out. Some of the tools that Thomas spoke about previously start to build us a live data set, if you will, for the same sorts of purposes. So I think if we were to do the same sort of exercise now, we'd find that process of maintaining up-to-date information an awful lot easier. The currency of information we found varied enormously depending on the sort of information we were dealing with. So at one end of the scale we found that, for example, delivery of home care services was up to date because it was based on route planning by the providers of social care. Other less frequent measurements were less frequently reported, as you would probably imagine. So things like, trying to think of a good example here, the weight of children in primary 1 was kind of cited as a useful measurement, but we found that we just didn't have a sufficiently complete data set for it to be useful.
Okay, that's great. Thanks very much. A question for actually from us guys listening in as well. Is the information that you've got shared across community planning partnerships at a local level to help with the kind of locality planning?
So the LIFT team are developing a project with the community planning partnerships to enable sharing of the data both to and from the community planning partnership. There's a much greater recognition now that the predeterminants of health and the prevention and public health, as mentioned in the delivery plan for the health and social care partnerships, recognises that greater spread of community data where education and leisure, policing, justice all play a part. And if we are going to truly think about the co-production, co-design, development of services with people, that we need to understand some of those determinants of health and what services are available in the community greater than just health and social care services, what the community assets truly are when we get into developing and design. So there's quite a lot of work to bring that together, and greater work across the third and independent sector to look at what services that aren't procured can also be added into these data sets as we go forward over the next 12 months.
That's great, Diana, thank you. We've got a question in from Zoe Vance down in South Ayrshire. She was saying that they're progressing to implement a new social care system, and they're wondering whether they should be incorporating their KI number to their records now.
I would say yes. In terms of integration, and especially with linkage with other services, that would be ideal. And ISD currently offer a CAI matching service. So if they have records of people's address, or at least postcode, date of birth and name, they can do a matching exercise to match up that individual to an existing CAI.
That's great, thank you.
I would say it helps to future-proof your data.
Just can I chip in on that as well? I think, I mean, it's definitely, if you have the opportunity to do it, it will be to your great advantage when you come to do this sort of analysis. Make sure that you've got people signed up to the appropriate data sharing agreements as you go through that process. The value of it is enormous, but there's obviously a staged process to follow to get the correct data sharing agreements in place.
Okay.
And ISD can support that. They've been doing that across Scotland.
Yeah.
Okay. Zoe's also asked for a contact to discuss that part of the project, so I'll just, and for everybody else as well, can send on the details for you guys afterwards and all the resources and things like that, and you can connect up with her if that's all right.
Yep.
That's perfect.
Okay, just wondering if anyone else has got any other questions we want to ask the team before we finish up today. Okay. Zoe's just sent us a wee link as well, which we can share with everyone. There's a data analytics group meetup as well, so we can fire that on to anybody. You can share that and send out the slides. Thanks, Zoe. Okay. I think that's maybe everything for today. Like we said, we can follow up with you guys if and share all your information online in the Knowledge Hub, and if anybody else has got any kind of more detailed questions, they can send them on to you if that's all right.
I think that's fine. It's quite difficult to do some of this stuff justice within an hour.
Yeah, I know. Well, thank you very much for your time today. Just going to give a wee plug to the Change Managers Network if anybody's not already a member of it. I think hopefully you should see that on your screens just now. We can send out the link to that. That's just our Knowledge Hub group where we'll have all the information from today on there, and you can share it and add members, etc. within your own organisations. So really it's just this kind of final thanks very much to everyone for taking part and for listening in today, and hope to see you in the next session. Thanks very much.
Thank you.
Thank you, everyone.
Thanks.
Thanks.